everyone to this session on preoperative and postoperative management. I have Jeffrey Lippman from NYU joining me up here. I'm going to go through and have all our presenters come up, give their presentations, and if you can stick to that 8-minute mark, we should have one time for questions per person. Just right and we are all that holds you between now and the cocktail hour. Just try to stay on time here. So the is from Carolina's Medical Center is Alexis Holland. We'll be talking about limited or lasting. Is preoperative.
Thank you. I'm a surgery resident at Carolina's Medical Center, and I'll be presenting on our long-term positive optimization for abdominal wall reconstruction. Our disclosures. Data that obesity is a risk factor for both initial hernia formation, hernia recurrence, and wound complications. Results produces intra-abdominal volume, which helps facilitate fascial closure and prevents the separation techniques and a bridging mesh. Improves patients' overall health and decreases healthcare costs. Well studied though is if maintenance of this preoperative weight loss. We put a strong emphasis on prehabilitation in our tertiary hernia center practice. Our efforts date back to the early 2000s and include destruction. In our prior literature, we have demonstrated some of the practices on hernia-specific outcomes. For 1,800 of our pre-peritoneal open ventral hernia repairs found that after optimization, diabetes and smoking were no longer predictors of wound complications. Yet with every point increase in wound complications increased too. Until this point, we had patients continued or sustained this optimization. For preoperative weight loss, we regularly with patients every 4 to 6 weeks for weight loss progress. If patients are not successful, and refer them to a nutritionist, or often a bariatrician for further. In this study, we sought to assess whether patients maintain weight loss postoperatively. Our prospectively maintained hernia database for patients in 25 at the date of surgery and at least 10 pounds of preoperative. We found 256 patients underwent 2 postoperative time points. First, at their 6-month supportive clinic visit, and second, at their most recently documented. When looking at our cohort's clinical information, it was about 52 years. And as expected, most patients were comorbid, 0.5% being diabetic, 7.8% having COPD, 7.9% being ASA class 3 or 4. 9.8% had undergone bariatric surgery. These being before the actual initial consultation, and large, an average area of almost 300 centimeters squared. 40% of cases were contaminated to some degree, and 5% of patients require component separation techniques to further diversity of these cases. Postoperatively, the length of stay was 7 days. The overall wound complications occurred at a rate of 27%, the admission rate of 5.9%, and a recurrence rate of 5.1%. Of surgery, the average amount of preoperative weight loss was 20 pounds, with a minimum of 10 pounds as our inclusion criteria, maximum of 120 pounds lost. Average BMI from 38.2 to 34.0 over an average. At the first postoperative time point, being 8.4 months postoperatively, had 1.8 pounds. From the date of surgery to the most data point, which averaged 42 months or 3.5 years, 4 pounds. This graph demonstrates patients' change in weight over time. The blue line is the overall change, which is a net loss from their to the time of their most recent follow-up 3.5 years later. We also found that it was just under a year postoperatively when patients declare whether they were going to continue to lose weight, or whether they would begin to gain their weight back, demonstrated by the red line. After surgery, 47.3% continued to lose weight. Average total net weight loss 44 pounds. Although a portion of patients did gain some weight early, 83.3% of patients maintained some degree of weight loss and remained at a lower weight than their initial weight, meaning that only 16.8% of patients gained back all of their loss. Although the majority of abduction surgeons agree on the deleterious effects of obesity, there remains some controversy about the risks and benefits of preoperative optimization is the risk of incarceration. Are certain hernia characteristics which may prompt the surgery in a more expedited fashion. The risk of incarceration of surgery is quoted anywhere from 3 to 7% over a 5-year time, which is predominantly low, particularly when considering that we are patients in only 10 months. A merger of parents carries itself, however, which is only compounded in the morbidly obese. The risk of waiting is another aspect of preoperative is the potential inequity in attainable weight loss. Described that obesity itself is unequally distributed across the population, with higher rates of obesity in low-income minority patients. Say this is even more of a reason to pre-optimize patients. Patients are patients that have a greater need for our counseling and persistent follow-up to help them achieve their weight loss goals. Some surgeons may not spend the time and effort to pre-optimize patients continue their weight loss, or at least maintain their efforts postoperatively. Almost 50% of patients who pre-optimize in our study continued to lose weight postoperatively. Another 22% maintained at least half of their preoperative weight loss. Separate 12% gained back some weight but remained net negative, ultimately totaling over 80% of patients who maintained some long maintenance of the preoperative optimization over a 3.5 years. From prior literature, we know loss is lasting. We conclude that the time and effort spent on preoperative optimization worth the long-term benefit for our abdominal wall reconstruction patients. We would encourage other practices to implement this preoptimization. Thank you.
Thanks, Alexis. Any kind of specific pre-optimization was associated more with long-term success? There were some GLP-1 use too that was especially successful.
We didn't necessarily delineate what particular type of weight loss technique is successful. So I was actually very surprised. I don't know if it was just my experience, and 2% of patients that were on GLP-1 agonists. I think maybe it wasn't as in vogue during our time frame, but now it is. I think that we would say that the majority of it is a ketogenic diet and persistent follow-up. Surgery, 9% of those patients had undergone bariatric surgery and they still required weight loss. So I think it kind of boils down to lifestyle changes that are able to be maintained even postoperatively.
Success with pre-optimization.
Just one more quick question, if there's none from the audience. So how is this going to change your practice now at your 1-year visit? It's really clear that it would try to
I think
steer
it's
the wall.
the need for long-term follow-up in hernia patients. It's kind of when we discharge discharge patients and say, you know, "You're doing a great job and everything is going well, it's going well, you can kind of go back to your own devices, or maybe it's at least having further phone call visits or things like that, keeping your patients accountable and help them maintain weight loss off bandwagon and the need to be referred back to their PCP or to help stay and maintain that weight loss.
About the impact of glucagon-like peptide 1 agonists in up and down abdominal wall reconstruction patients.
That's one interesting fact about me. So 1 in 5 adults are going to be diagnosed with ventral hernia, and in the last year alone, about 600 underwent surgery to repair their defects. We look at for determining for the patient is their weight, because morbid obesity is associated with postoperative complications, recurrence. And so we try to optimize the weight. In the past, we've used bariatric surgery. It's very effective, and you have gastric sleeve, lap band, vertically banded gastroplasty, biliopancreatic diversion. The way that these surgeries work is that they cause mechanical restriction, physiological restriction of caloric intake. Recently, there has been a new drug class of medications approved that's unlike peptide 1. And so the mechanism of action for these drugs is that they promote insulin and satiety. They also inhibit some of the adverse effects can be nausea, diarrhea, gastroparesis, and constipation. And last year, semaglutide drug expenditure, and the study aim was to compare the efficacy of the receptor agonist to bariatric surgery, weight loss prior to abdominal wall reconstruction. We also wanted to see the effects of operative outcomes. And we also wanted to determine the impact on post-operative outcomes, because like I mentioned in the previous slide, so our null hypothesis was a difference in time to surgery and changes in weight. Our alternative hypothesis was that the GLP-1 group increased rate of ileus and delayed post-operative bowel recovery. And so this is our methodology. What we did is we looked at patients who had a diagnosis, and we looked between January 2021 and then we excluded 6 because they either didn't require a weight loss intervention, or the weight loss intervention was not related to reconstruction. And so in total, we only had 5 patients that were optimized before the wall. And so we had 18 who received bariatric surgery, who were on a GLP-1 medication. And primary endpoints were clinic time to surgery. The first time we saw them in clinic to the day of their hernia repair. Intervention time to surgery, which was when we started the the GLP-1 medication or when they have to do the hernia repair time. And then we also looked at how much weight they lost. Our secondary endpoints were surgical site reduction and length of stay. And so the average age was around 57, they're about the same age. This was at the bariatric surgery group, actually lost more GLP-1 group. And so as you can see, they lost 27 kilograms for the group, and then in the GLP-1 group, they lost about 15 kilograms. Had ileus or a higher ileus and respiratory failure. This was something that we were kind of expecting for the ileus. The study was the retrospective nature. There were a couple of biases or potential bias of recall and selection. So it's pretty low. So in the future study, we restricted it to teenage injections just because most of these injections specifically for obesity as opposed to diabetes. But maybe in the future we can also and bariatric surgery lost more weight prior to reconstruction. The GLP made it faster than the bariatric surgery group. Their length of stay and their intraoperative procedure time was about the same. And GLP-1 receptor agonists are a safe, non-invasive method. Abdominal wall reconstruction, pre-optimization. Any questions?
If anyone has any questions, please come up. I have one great question for you. I'm not sure if you have this data, but because overall it seems the weight loss in kilograms was low compared to standard bariatric surgery. What the amount of weight loss, they get their surgery once people get their surgery at a certain time frame.
Oh, yeah. We had their weight. We collected their weight whenever we first saw them in clinic. Collected their weight the day of their surgery, and so that's the talk. Any other questions?
I had a quick question, just in terms of, at least now we have some advice from our anesthesiologist about how long we have to hold GLP-1 agonist before general anesthesia. Or not, and I'm wondering if that would influence the postoperative ileus.
The Beverly Hills patient and outcomes.
Good afternoon, everyone. Thank you for being here, the opportunity to present our work. To disclose. So I don't think, I need to tell everyone here that we're all aware that inguinal hernia repair is one of the most commonly performed in the United States and in the world. While there's increasing aging and prevalence of inguinal hernias, there is actually limited evidence of age and sex on patient presentation and the expect optimize their care. So in this study, we reported symptoms from inguinal hernias stratified by age and differences in their outcomes after tailored inguinal hernia repair. So to do this, we performed a retrospective review of surgeon hernia database, including all patients who underwent hernia repairs from 2009 to 2022. That preoperative characteristics and we use the 65-year-old as the and also use multivariate regression analysis to adjust sex. So here's our results. We had a total of 494 patients included in the study. 120 of them were 65 years or older. We did see some significant differences in groups. Specifically, the older group were more likely to have COPD, diabetes, and again, we saw some differences between the two groups. Specifically, the older patients were more likely to be asymptomatic, less likely to have pain with lower pain scores, and less likely mutations. There were no differences in the use of opioid rehab. However, after adjusting for sex as well in our multivariable analysis, some of these differences were no longer statistically significant. For adjusting for sex-based differences, there are still more or less symptomatic at the time of presentation. So then, if you want to look at the preoperative symptoms a little bit more closely, the quality of the pain, as well as the location, the radiating to the back, to the leg, are they having sexual symptoms, and after adjusting differences, the older patients remained less likely to have it down to the back, down to the leg, into the scrotum, and such. We found that older patients were more likely to have repairs versus minimally invasive repairs in the cohort, even after adjusting for sex. Additionally, if you just look at the compared and younger group, the older patients it seemed like they were less likely hernias at the time of surgery, and more likely to have direct hernia mesh as part of the repair. However, after adjusting these differences, the only significant difference remains is the increased response. Although seemingly the older group, if you just looked at the numbers, less pain post-op, this is that short-term follow-up, higher symptom resolution and 95.8% versus 89%. However, after adjusting for sex differences, those differences were no longer significant, and similar post-op pain scores and resolution. Our study is limited by the retrospective design, higher proportions of female patients, and offer a tailored approach, offering all options when it comes to female, and we do have limited long-term follow-up. Conclusion: patients that are older different their counterparts. So at first, it seems that younger patients have more mutation. This is more of a consequence of sex-based than age-specific factors, at least in the patient population. And since we treat a substantial female population in characteristics and outcomes. Thank you.
Thanks, Harry. Do you have any hypothesis for why in kind of preoperative pain characteristics?
Yeah, so I think specifically when we we first, we actually set out to just looking at the difference between the age groups, and so, and we saw these different outpatients who come in with nuanced symptoms that then kind of contributed to a lot of the adjusting for sex. Those differences, a lot of them are different. But we do know, the inguinal hernia, as well studied as we wanted to be, right? So abstract just kind of contributes to, and they tend to have atypical symptoms. Sometimes they don't have a bulge. They don't have like kind of radiating pain to the back, rather than like just pain over the significance of sex being a factor.
Yeah, and I also thought it was interesting that even though the symptoms were somewhat atypical, pretty good symptom resolution in the less than 65 or the female kind of cohort age maybe suggests that we need to think about symptoms for people with not necessarily as large clinically evident hernias. And yeah, exactly. Next, tell us about a review of postoperative care for ventral repair.
I'm a third-year medical student at the University of Tennessee. I'll be presenting a review of postoperative care and ventral hernia repair. AHS for having us, and the moderators today, and y'all for being here. So although postoperative care has the potential to improve outcomes, there is current quality evidence-based guidelines. Some evidence for antibiotic prophylaxis, negative pressure, abdominal binders, as well as activity restriction. This figure shows the process. Original search terms were broadly related to ventral hernia repair and that base. We then removed duplicates, conference abs. Then had a team of 4 residents and 3 medical students. Further filter lists and our inclusion and exclusion criteria. Overviews which specifically focused on postoperative hernia care. Guidelines for antibiotic prophylaxis, that prophylactic antibiotics given as a single perioperative dose is just used for umbilical or epigastric hernia repair. You write that these antibiotics are reduction in infectious risk, and potential drawbacks include side effects, antibiotics, the costs associated with increased medication. We identified multiple trials and reviews on the topic. However, they did not enter in terms of what the protocol and procedures were between each included. These are the 3 first was in 2019. It included 4 studies. It showed support for use of antibiotics to decrease infection. The next was a review from 2006 studies. This looked at abdominal wall hernias with no significant impact when antibiotics were used broadly. The third was from 2019. It included studies. This one looked specifically at the use of antibiotics in ventral hernias that also had closed suction drains. Again, show any significant benefit. And the 3 each encourage more evidence-based guidelines for antibiotic use in ventral hernia repair. Into negative pressure wound therapy on the right. Currently, Hernia Society has not provided any list for ventral hernia repair. A Cochrane review look at incisional and abdominal hernias. Did no evidence to provide recommendations. That review was done in 2013. 10 total studies. It found a significant decrease in infection, seroma, skin necrosis, wound dehiscence, and no different recurrence. The next in 2022 was a review 12 studies. This recognized in surgical site infection with no difference in recurrence. Third was from 2016, randomized controlled trials. It found decreased surgical dehiscence and hernia recurrence with no huge, which were primarily financial analyses. These did not directly what they did. No increased upfront cost and long-term cost savings in specific patient populations. Conclusion, obviously, these results are somewhat mixed between. They do show that in patients with higher risk, this wound therapy may be helpful. However, it's really going to generate good evidence-based guidelines and provide support for the patient. Right, like no recommendation can be made for or against the use of postop due to lack of data on incisional hernia or birth abdomen. They write that it's weak quality of evidence, and recommendation strength is weak as well. We identified one review looking at abdominal binders and hernia. This included eight total studies. Studies related to abdominal surgery, including but not limited to vaginal hernia. They noted no significant finding or improvements. They did note that in this, the pain score between the studies they included were different, so it was difficult to make any object from this. The only significant finding they had was a postoperative physiologic distress. This was also somewhat unclear, as this was not a measure that was included. Looked at. Activity restrictions for post-op activity restriction repair and the after open abdominal surgery can be made. There's not an equivalent statement for recommended laparoscopic or minimally invasive surgeries. Use that looked at this for ventral hernia repair. The first was looked at 3 studies. It noted too little evidence to make any sort of recommendations. The next was also it was a review and a study, a survey of experts at the European Hernia Society. It found that many experts in ventral hernia repairs. However, this range of time pretty drastically between size of hernia, surgical technique, as well as patient comorbidities. Review, some experts recommended 2 weeks and up to 7 weeks and longer for others. 4-week time span should be increased for complex hernias and patient morbidities and risk of negative outcome for them. Postoperative care. Patient of post-op adjuncts does have the potential to decrease pain. Other negative outcomes, especially in high-risk patients, for antibiotics and the negative pressure wound therapy. To continue to produce quality studies, evaluate the emerging evidence, and update guidelines. Thank you. These are the references.
Hi there, Sean Warrantino, which is the antibiotic one. So with that literature, which is there's no evidence to support the use of antibiotics for place. I would argue that there are signs. American Society of Hospital Pharmacists do still recommend that. Question for you is how are you guys? Are you going to not give antibiotics when mesh is placed? If you don't do that, what happens when that patient gets from skin flora?
and not applying the antibiotic. So I think that's something that could probably be studied more, which patients need the antibiotics and are at lower risk for infection. But it's definitely, that's a great point.
Thanks a lot.
All right, next up, we have care of the health. Visualizing metastatic squamous cell carcinoma and possible over-optimization in ventral hernia repair.
Everyone, my name is Kara Button. I'm a third-year general surgery resident at Portland, Maine. And in the everything session and by some of our presenters earlier in this session. Optimization is a commonly practiced strategy. It's well done literature, and it modifies patient-specific risk factors to the goal of possible operative outcomes. The overall goal of intervention with physical therapy, smoking cessation, loss, nutrition supplementation, and diabetes management. However, more recently, the studies in care associated with optimization have become a topic of literature. And these costs and complications are highlighted further. So the 72-year-old female with a history most notably of 2002, where she had an open primary umbilical hernia repair. This was followed by 4 subsequent operations in 2004, 2005, in 2011, followed by a mesh explantation in 2011 with a vicral mesh. After that, final operation in July of 2011, she developed on her abdominal wall over her hernia. Ultimately, the patient was referred to the hernia clinic and given her BMI of 54. She was bariatric center for consideration of preoperative weight loss, able to lose 40 pounds, but ultimately regained the weight. In 2023, she presented again to the hernia office to discuss elective repair again, but her BMI was still great, so she was referred to a wound care center and was lose weight. Her overall weight loss goal for this operation was over 100. Unfortunately, later on in 2020, over her abdominal wall, concerning for an enterocutaneous fistula. At this time, an exploratory laparoscopy was done, which found that she had this fungating mass of extended venous tissue invaded into the abdominal wall, in the bowel, and there were obvious metastatic nodes in the and small bowel mesentery. So she had small bowel resection, and then she had resection mesenteric and omental nodes. She had closure with a bridging vicral mesh and soft tissue rearrangement. And there's a photo of her postoperative. Final pathology demonstrated squamous cell carcinoma with invasion into the small bowel, mesenteric and omental lymph nodes positive for metastatic disease. She had a prolonged hospitalization and complicated post. About 2 months post-operatively after she from her hospitalizations, She had a CT scan, progression of disease. She at that time elected to forego therapy and ultimately succumbed 4 months after her operation. Hernias are prone to wound formation and ischemic ulcer. And this is a series of photos dating from 2023 showing her abdominal wound. That's not captured. So chronic wounds are known to be a risk factor for developing tuberculous ulcers, inflammation, repeated re-epithelialization and radiation, overventral hernias that can contribute to their formation. Marginal ulcers can take months to years to develop. Long-term wound care therapy, like our patient. Several providers and subtle changes to the wound still unnoticed until. So although there are studies that create favorable outcomes in patients who undergo preoperative optimization, data on complications for those not achieving optimization. And in our case, unfortunately, her prolonged pre-op period was a factor in her developing medicine. There's even less data about patients suffering from chronic morbid secondary to their lack of treatment and inability to reach only about 10% of patients who are undergoing preoperative optimization actually get their elective surgery. And there's a percentage estimated to be 3 to 5% of patients require surgery during that optimization period. But more difficult is the negative impact on the quality of life that patients report while living hernias. There are limited studies that focus, but there is evidence that patients who have a prolonged period and live with their ventral hernia, straight obesity does increase the risk of lesions. BMI cutoffs can be arbitrary. Most don't lose meaningful weight during preoperative optimization period. It also takes significant time and resources to lose weight, smoking, and patients who fail to meet these goals undergo surgery. A study by Al-Mansour et al. Actually presented earlier today that these cutoffs that we give patients for optimization of distress. Varying criteria across also causes a different proportion of patients that eventually surgery. And those who don't have the optimization goals met have a lower reduction in the rate of them actually achieving surgery. And this suggests overall that optimization cutoffs may actually be a barrier to some patients receiving care, rather aid in their surgical outcome concept, and offers significant to some patients. However, the true cost of optimization is not all patients are successfully optimized. So time to surgery can lead to reduced quality of life, need surgery during an optimization period, failure to receive surgery, and unfortunately for our patient, it led to her death due to medicine. There is a clear case for further into the impacts of optimization and the risks of non-operative management, individualized risks and benefits of ventral hernia. Thank you.
One quick question. So I think it's a really interesting case. Retrospectively, obviously hindsight, but playing Monday morning quarterback, would you have fixed this hernia and team, or would you have optimized her differently, like tried to do the optimization differently?
Was optimized somewhat. So she reached about 60% of her 40% of her weight loss goal. it seems that she was lost to follow up at that time, and ultimately had some mobility issues. Unclear in her chart whether or not there was follow up at that time. She's kind of lost in the records for a period. I think at that time it would have been reasonable for notably, it was something that was never biopsy at that time could have been really beneficial in developing this.
I just want to pull the audience really quick. Who would have fixed this hernia for the big wound? Who had a BMI of 50? Except Heidi. 2020. No. Yeah. Yeah.
Back to and say that this was a non-optimized patient, a surgery that led to a chronic wound that patient advance. I don't know if it was necessarily the the hernia itself, this squamous cancer, but maybe just that different we had from the failed hernia repairs that led.
Well, I think it's a point that she was in that vicious hernia cycle that we had operation, reoperation. And you make a great point that, going even back that far, it's really hard or not that repairing her at that time was due, especially since our medical records from 2002 were, that's about it. But it's hard to see set her on this cycle.
Yeah, I don't think they're right, really complex cases, but I do think that it making it too easy if we just say we would have fixed her and she would have been fine. It's not just us, but the burden falls on us a little bit. But I don't know, I'm biased, I strongly believe still. But I think the system fails us, right? And that's where these happen because patients don't have access to the bariatric surgery that they need, one agonist that they need, or, that's a whole system that hope someone can fix, but I'm not sure. I know.
To be clear that my point is certainly not against preoptimization. Okay.
One that we hope we never see will be also. If you look back 25, 30 years ago, optimization or prehabilitation wasn't a word. We all held them looking for 6 weeks or try to lose a few pounds, but we did their surgery. And then we learned later on, getting a BMI, et cetera, diabetes under better control. We would do 1 or 2 if they had a program. And in the last few years, when we've been focusing on, we still have a lot of unanswered questions. How long do you wait? 3 months, 6 months, bariatric surgery, or have a hard time getting in? Nowadays, they can't get insurers, they're too expensive, or they're just not available. So, those guidelines, and I don't know how quickly we're going to get there. You can blame society, you can blame the you can blame the patient, you can blame the surgeon. Still learning.
We have Carlos Silveira from my alma mater, is view and meta-analysis.
Good afternoon, everyone. It's a really big pleasure being here. On behalf of my research group. I'm from Brazil. I'm actually a research fellow at Big Health Hospital in Phoenix. And today I'm going to present a review analyzing the impact of sarcopenia, sacral hernia repair outcomes. Closures related to this work. First, we need to understand why it is important to recognize sarcopenia, analyze sarcopenia as a comorbidity. I've been talking all this session regarding prehabilitation program, diabetes, analyzing weight loss. Those are comorbidities that are well understood to sarcopenia. We have one hernia, and we need to first identify it is really a risk factor for following ventral hernia repair. Sarcopenia is defined as a reduction of muscle mass. It can be associated with advanced age, but also consumptive syndrome such as cancer. Previously, it was diagnosed based just on the definition of the hernia is CT. We have these cutoffs that are different for men, and we have 52.4 square centimeters per meters, and for women we have 38.5. And we need to highlight that it's a broad comorbidity. It can be with obesity. We can have patients with a loss of muscle, but also an increase in fatty. So the outcomes of patients undergoing ventral hernia repair. Our eligibility criteria for the patient ventral hernia repair older than 18 years old, and it's comparing sarcopenic patients with patients without. We only included patients that underwent diagnosis by tomography, and we personal studies. We searched med Cochrane up to April, such as surgical site infection and length of hospital stay. Of a total of 263 studies, we got a final number of only 3. As I said, it is really low literature on sarcopenia, so I think of this presentation, we need to understand the papers that we have published are really heterogeneous. 275 patients, of which close to 100 in the sarcopenic group. Mean age range 57 to 63 years old. And interestingly, the control group, without sarcopenia, they have a higher BMI in 2 of the studies, but in one study that analyzes patients with concomitant sarcopenia, and the groups were well balanced. Was higher in the intervention sarcopenic patients. Expected first that sarcopenic patients would have rates, low muscle mass. Imagine that it could be associated with difficulty in fixating the stitches, fixating mesh. We found no differences between the groups. Also for surgical site infections, no differences were found. Occurrence rate for the patients without sarcopenia, but we truly believe that only 2 studies included in this meta-analysis and heterogeneous, then this data may be not. Also, we found no length of hospital stay. So based on those baseline notes that we have, very heterogeneous data, all the studies active and didn't use statistical methods for matching for control for other comorbidities. So we didn't control for diabetes and other comorbidities. But we provide the first systematic review analysis on this topic. So we got the large combined sample, large enough. We have only 170. Up to date, we do not have data for surgery due to sarcopenia. And this definition need based on the surgeon's experience and evaluation patient profile based on the other comorbidities. And I think also it is a cliche, but we need more studies analyzing and also analyze sarcopenia combined with other comorbidities.
A great study in summarizing that we need more literature. One interesting finding that our study, the Siegel 2018 study, that we pointed out was that most of the sarcopenia literature is based on, and where there is clear correlations between worse sarcopenia compared to people that did not demonstrate sarcopenia. What we did was if you recalculate things using different, the cutoffs that we utilize, a very different pathophysiology of elective hernia cases. And so if you change assumptions using different thresholds, it actually did start to show statistical significance between the groups. So if you are doing future studies, you may want to change some of those calculations, whether it be analysis or some of the other mathematical things, and actually significance, because it's a very different population. But great job on this paper.
Thank you. Yeah, we believe that this is really important. Its relation with cancer, but mainly distinguished related with advanced diseases and or cancer. But a common diagnosis, especially here in the US, sarcopenia associated with obesity. There is just one paper analysis. We think that maybe they will show more. We have more tension on the abdominal wall associated with the loss of. Thank you.
Seems like you have a lot of projects for your research. So thank you. Aggressive preoperative knee with fascial closure and loss of domain, a retrospective review.
Thanks for having me. I'm Ben. I'll be present, exactly what she said. So we have. Yeah, big green button. All right. That's a preoperative pneumoperitoneum is one junk we have for large hernias, especially high loss of domain. The first surgeon to PPP for these large hernias was Ivan Moreno, who was an Argentine surgeon, and he described it for penetrations, and he was just using a needle, feeling that up and insufflating the abdomen serially over several hernias, large inguinal hernias, and also hernias without this domain, but with high width, although the most common indication in the nowadays hernias with high loss of domain. More recently, there were two papers by Tanaka and Sabah with their own method to quantify and try to establish thresholds for when we should be using. Image that I've cannibalized from a recent consensus statement on how we should be loss of domain, but I just wanted to bring this up to kind of point out this is how we'll be describing loss of domain in this study. That was an institution, even though the consensus criteria does adopt is maybe the preferable method. So we hypothesized that PPP would be the critics of this method say that it's been shown to increase the size of the abdominal cavity. It's been shown to stretch the muscles of the abdominal wall, but it's really unclear to what aids in fascial closure. So we hypothesized that it would form a retrospective cohort study among patients with domain comparing PPP to no PPP. Was a retrospective chart review. P group was just all patients PPP since we started doing it, which was back in 2008. Meanwhile, the comparison group was drawn from patients who underwent retromuscular repair. Intent of the database was to examine changes in the abdominal wall. So this wasn't a database necessarily customized for study. No patients were excluded after inclusion, more than 20% by the Tanaka method. So like I said, this was a chart review. All patients had preoperative CTs. Rather, we looked at all the patients' preoperative CTs. Notably for the PPP patients, we do preoperative CTs before they get, and also after the installation of them, but before their definitive repair. So they get 2 CTs. Perhaps CT in this study we mean. So we had 51 PP group, of which 45 had complete CT data. The non-PPP group, once again, this is a database who had brief STOPA repairs. So 41 patients met the cutoff of 20. Of those 10 were in the field. That meant 31 patients with high loss of domain, but that did not undergo PPP, of which complete CT data. The next couple slides are best all summarized. They were both tended to be very safe. High, medium BMI in the mid-30s, 20% about smokers in each group. This is a table of technology and operative details. And note the hernias in the PPP group are significantly larger, both by rec and by Tanaka score. There were differences in operative details. Find that the inclusion criteria for the comparison group was that it had retromuscular repairs. So as you'd expect, they almost muscular mesh. Whereas in the PPP group, 10% of our patients had onlays. 70% had retromuscular. These 7 patients who had needle underlays, those were all very early in years. The PPP group had more recurrences. So higher recurrence rate, more readmissions, probably durations, even though our study was probably not to detect that. Most of the readmissions and reoperations in the PPP wound complications. Usually skin separation, treatments, back placements, that sort of thing. And here's a long list. It's just every it does encompass complications from the PPP itself. Prior series have shown incidence of complications to about 50%, so it's 25. So in this retrospective review, patients who had bigger hernias, more complications, and fascial closure with patients in the comparison group. Our institution, we have a much higher threshold for PPP due to the,
Can I ask, is your group using Botox also?
Botox is variable, it's not routinely used with the PPP, and it's often in the wide. So we use PPP for domain. The Botox is more often in large hernias, wide hernias, but not much. I think the PPP works. So, you know, those hernias that we're doing PPP on are massive. I do think that there's a benefit to PPP. I'm not sure that this is the study to necessarily show it. You know, and low incidence.
Thank you. So PPP versus no PPP, that last table showed there are more PPP, more complications with PPP. So take home message is.
But in a group where, because I don't know, asking is your take home message, don't do PPP.
I think it's really ambiguous study, our comparison group is from all comers. We're taking just retromuscular repairs. I mean, we're comparing apples to oranges. Hernias in Greenville get PPP. It's really hard to have a comparison group. So this is our time to have a comparison group.
Thanks.
Yeah. Okay, next is Benjamin Reed. Oh, I'm sorry. Next is Tara Randbar, who's going to talk about 6 months of patient optimization, reducing complications in abdominal wall reconstruction surgery.
My name is Tara Ranjmar. I'm a first-year resident student, providing me with this opportunity to be here today, as well as thank my mentors for supporting guidance. My project is called 6 months of optimization, reduces the risk of complications in abdominal surgery. As you all may know, is a protrusion of the abdominal tissues or organs in the abdominal wall. Smaller ventral hernias can often be cured by abdominal wall reconstruction surgery with component separation and mesh reinforcement. Our method was that we took 52 patients who went abdominal wall reconstruction surgery over a time of years, performed by a single surgeon at a single, and we obtained their modifiable risk factors like BMI, hemoglobin A1C, at their initial clinic visit. That time, their first visit up to the date of surgery, we extended the patient on adopting healthier habits to reduce the risk of complicated with surgery. We did this through encouraging healthier habits like weight loss, partaking in physical therapy, also would reduce the risk. We calculated the risk of complication by using the Caroline, determining a series of questions such as whether or not controlled diabetes, which is measured through a greater than 7.3%. If they have previous hernia repair, they have a stoma present or erection, and whether or not the surgeon plans on using operation. After inputting this data, we add with the percent risk of complication for that particular, as well as the in-hospital charges and follow-up charges. table shows the preoperative modifiable risk. Our counseling reduces the risk of complication. And for active smokers at their first initial outpatient visit, and through our counseling, one of them quit smoking. But one patient that did not, he actually did, but he ended up smoking the day, so we still took him to the OR. Patient had a hemoglobin A1 standard deviation of 1.7. Through counseling, we were able to reduce that value to 6, showing a 14.7% change reduction, which was significant. As for excess body weight of 27 kilograms with a high standard deviation of 4.6. Through counseling, we were able to reduce it to 25, deviation of 13.2. Yes, this changed so, but it's because we had some patients lose. And lastly, for BMI, we were able to have a 1-point reduction, not statistically significant, but approaching at a p-value of 0.06. Counseling, we found that the risk of complication was reduced and statistically significant. As for our patient demographics, a majority of our patients are above the age of 50. The average age is 50, and 21 of our 53 patients, which ranges from 5 to 30. Found that most of our hernias were benign hernias, and that there was really no difference as to having a midline hernia resulted in a or a hybrid minimally invasive converted to open surgery. 40% of the time, the patients with midline hernias underwent as opposed to the 51% who had a convert to open. Significance in the type of surgery that these underwent. 41% of our patients with loss had a hybrid procedure in which we began minimally invasive and convert to open, as opposed to 4%, which for the as I mentioned earlier, the counseling was 6 months from their first out up to date of surgery, and most of the patients previously had another hernia repair. The injuries that these patients underwent, it was pretty even in MI hybrid. 47% of our patients had minimally invasive surgery as opposed to 53%. Some of the reasons as to why we would convert to open, inability to progress through the surgery as MIS, ability to maintain pneumoperitoneum, to remain totally extraperitoneal, and yet a decreased length of stay that had a hybrid surgery. This was statistically significant. So how we measure the hernia sacks. Patient is 12 patients with the loss of domain. We took biopsy and we measured the axial view, the coronal, and the sagittal view. Conclusion: we found that encouraging in most aspects. Unfortunately, some of the data could be wide range of change, whether the patient gained weight or lost weight. Patients did undergo a successful closure with no readmissions. We did have a 3.7% recurrence, means that two of our 53 patients had a recurrence. In the future, we do plan on expanding registry to patients in our patients and affects the surgical outcomes.
move on because we're just a little bit behind. Next, I have Luis Fernandez Vasquez Milado, is from the hospital. We'll be talking about the assessment of risk factors and meta-analysis, analysis of retrospective cohort studies.
Hello, good evening. I'm Luis Fernandez. Conflict of interest. Why? Incisional hernia as worldwide reported by almost 13%. We see a lot more of this. We augment the follow-up maybe 40 to 69%. So just imagine more than half that are getting a laparotomy is the database of what is so different from country to country. We are different. Our bodies heal different. Because there are some incisions made in Africa, there are incisions made in America. That we know that the follow-up should be done at least 5 years. If we want to really assess our rate of hernia. And then we are losing because now it's a CAT scan. But we are losing patients that are asthmatic and maybe they have a little hernia and we don't know about them. So maybe that's how we can get to make a better follow-up. Traditionally, risk factors or two big groups of risk factors: controllable and uncontrollable. What's up? We have 11 studies. Sightings. We have the 5 risk factors, 5 reoperated and SSI. Mexico, if I see a patient that his B5 quite lean, to be honest. We are the same as here in America. So it is really important, the BMI. So our goal was to assess the risk factors. Our aim was to identify magnitude for each factors. The checklist method, one is to analyze pediatric patients, so more from 15 years or older, explicit reporting, no time limit, no language restriction, and the quality control was achieved. Our risk very low. Is it true? Do we really have worldwide a prevalence of 5? Look, meta-analysis came from these countries. This is the number because our team did that study. But we are lacking data from almost all of Asia, all of Africa, and now categorization of risk based on attributable risk and its difference. On the left, you can see Asian descent and age. These factors that we found a cutoff. The thing that we found is if you are younger and if you are older, you can have a less risk than having an incisional hernia. Bottom of this, the worst, and we found that this is clinical. Is a reoperation during hospitalization, all 5-fold. So maybe our aim is extra mile and treating endoscopically. And if we have an abscess and we have bleeding, maybe we can treat it pharmacologically by placing a cath by our interventional radio. Drug and alcohol abuse. We found that found any statistical significance, okay? In reoperation during hospitalization, we found that sites were the biggest one. The essence surgery, which kind of emerging surgery? Colonic, gynecological, oncological laparotomy, statistically significant risk. But if you have an emergency for a ruptured an aortic rhythm, that's statistically significant. You have bigger risk of hernia. So in green, in blue, you see a risk factor that without any significant statistical. SBO, SSI, drug and alcohol produce, no, why, we don't know. Make analysis, there is no cutoff. How much do you drink for one bottle per day, one beer a day, 1 liter, we don't have a hospital can make you almost 5 times, so it's a worst risk factor to having an incisional hernia. Maths don't lie. Crossing the unit, look at the chemotherapy. How many patients are we losing because we're telling them, you are too fat, go and run a mile, I can operate you. How many patients are opportunity today? We're losing patients that they are having a worse quality of life because getting them to preoperative. The optimization too harsh on them is really. And now look, the reoperation during hospitalization. A very different graphic than the last one. Conclusions. We propose a new way to classify risk factors and surgery related. We found that what the patient brings from home to the hospital. So maybe it's time for us surgeons to start looking ourselves, not at the patients. I want to repeat them, but this is what we found. Risk, but we have no statistically significant drop on alcohol abuse, emergency surgery, and malnutrition. Factors: Asian descent and age. Younger is less probable.
Did any of these countries you looked at have a higher rate of MASH?
No, actually, what we found is sufficient data and quality data for prophylactic MASH. That's a shame.
And last but not least, Caroline Rassador, transversus abdominis plane block for postoperative pain management.
Good afternoon, I'm Zana. I am a research assistant in research. Today I'm going to present thematic review and meta-analysis on the transversus abdominis for postoperative pain management after ventral. We have pain is a symptom very common in general surgery procedures, and this is associated with worsened quality of life, increased hospital length of stay, which consequently causes and also increased hospital readmissions. For ventral hernia repair, the postoperative things which tend to cause more pain. However, in light of the opioid epidemic in the United States, where 2017, two-thirds of more than 7 drug overdose deaths were related to opioids. Towards a multimodal approach for pain, which has shown to decrease pain, decrease opioid use, and obviously the opioid side effects, which most nausea and vomiting. This is abdominal spleen block, which was first described by Dr. Rafi in 2008. It blocks the neurovascular plane between the internal and the abdominis, and it can be performed with ultrasound or under direct visualization during the procedure, and it can be used simple bupivacaine or liposomal bupivacaine. And it was shown by previous studies to reduce postoperative pain, reduce opioid requirements, effectiveness of the transversus abdominal spleen block, postoperative pain management for following ventral hernia repair. From our eligibility criteria, we select observational and randomized studies, including patients older than 15 undergoing minimally invasive or open ventral hernia repairs. And from our intervention group, we selected the preoperative being performed with the guidance of ultrasound visualization. And for the control group, we selected analysis for each type of. From our search strategy, PubMed, Embase, Cochrane, Lilacs, and Web Sciences, and our outcomes of interest were pain assessed through the NRS scales within 6, 12, 24, and 48 hours. And the opioid requirements assessed through the morphine milligram equivalence. We screened 1,060 results and full text reviews. And finally included 14 studies. These 14 studies were 9 retrospective, 5 randomized controlled trials, including 1,117 patients divided following way, and 7 studies included only repairs, while 6 studies included only laparoscopic 2016 to 2024. 4 liposomal bupivacaine, and the others used simple. From the hospital length analysis, regarding the hospital length of stay compared with the conventional pain measures, the TAP block was associated with a shorter hospital length of stay compared with the measures, with a mean difference of more than 1 day. We performed a subgroup analysis, include results as the overall differences for the test for subgroup differences. As for the comparison between TAP block and epidural, we also had lower shorter hospital stay with even stronger results with a mean difference days. For the postoperative pain scale, comparing the TAP block with the conventional pain measures, presented significantly lower NRS scales immediately. However, after assessing within 6 and 12 hours after surgery, despite having significant results, this is probably not of significance. Rest of our analysis, no differences were seen between the TAP block compared to both epidural and systemic, and no differences were seen for postoperative pain comparing the TAP block with the analgesia. Finally, no differences with bupivacaine for As lim as limitations, we have several limitations. First is the retrospective interest, which causes important election to intervention. Also the use of hernias, we had umbilical hernias, incisional hernias, which most times cannot be compared in the same, but some studies didn't even specify the type of hernia. So we castly the multiple differences regarding the techniques. Some studies used intraperitoneal methods and performed retromuscular repairs, and also we could analysis on these different types. As conclusions of our study, I think the TAP block is associated with a shorter hospital length of stay from epidural analgesia and systemic analgesia. That block causes less postoperative pain immediately structured as an alternative for postoperative pain management and repair, along with the other techniques for multimodal pain. Thank you so much for listening.
Were you able to decipher if there was any difference between the ultrasound or us doing it in the operating room?
That indeed should be an analysis that we have. We didn't evaluate the necessity.
All right, well, thank you all very much, and please join us in the for the welcome reception.